And I'll invite Dr. SIMA Das, who is from Shroff Charity Eye Hospital, Delhi, to talk about retinoblastoma. Dr. Das.
Thank you, Dr. Anirban. Okay, so can we have the slides, please? So I'll be talking about the unholy glow. I mean, we are going from eyelid straight to intraocular, but I think next to eyelid, what you see is the glow which is there in the pupil. And I'll focus mainly on retinoblastoma, and if time permits, try to cover a few more intraocular tumors. So we all know about the white glow in the eye. A normal pupil should have a nice, healthy red glow. And if that is absent, there is something wrong in the eye. It could be a tumor, but it could be many other things. But what we have to rule out is a retinoblastoma, which is a life-threatening condition. So it could be sometimes because of cataract or PHPB, pupillary membranes. And we all know why this term, what we call is leukocoria or a cat's eye reflex is used. That's because of the reflex what we see in the cat's eye, and that's because of the retinal pigment which is there. And that's how it looks like many times. But unless proven otherwise, a white reflex in a child's eye is retinoblastoma, and at least that needs to be ruled out before we plan anything else. Cataract can also cause a white reflex in the pupil, but if it's a congenital cataract, more often than not, it could be bilateral, and if we see it under slit lamp, the white part or the reflex is localized to the lens and not behind the lens, unlike in RB where the problem will be in the retina or the reflex is going to be coming behind that. And cataract have different morphology, and a good slit lamp evaluation is enough to give you the diagnosis. Coats disease, we all know, it has retinal telangiectasia, sometimes present with a total retinal detachment, especially the stage 4 and the stage 5 disease. But it again has the characteristic appearance, going by the history, going by the gender distribution. More often than not, we will get the diagnosis, and B scan and a CT scan is enough to confirm the diagnosis. Ultrasound in a stage 5 disease will show a close funnel RD without any intraocular mass. Sometimes the exudate can be a little thick, which can give an impression that there is some intraocular small calcification sort of thing, but there is a typical after movement if we do a dynamic ultrasound, and that might help in giving us some clue that we are dealing with a coats and not with an RB. Other things like persistent pupillary membrane, we know that the eye is going to be microphthalmic. We can see the elongated ciliary processes. There will be a retrolental fibrovascular membrane. And a B scan again will show no intraocular mass, but a closed funnel RD picture. So these again are sufficient to give us the diagnosis. Now, once we have ruled everything out, a leukocoria, white glow in a child's eye is RB unless proven otherwise, and we must investigate further to rule it out. Because if we do not pick it up at this stage, this is what most of the children will end up with, and this is definitely something we don't want to see any day. Now, why it happens, why do we miss it? Because it's not always the child is going to come up only with a white glow. There can be many other variable presentation, what we call as the atypical presentations of retinoblastoma, and that's what is lets you miss the diagnosis. Now, if you see this child, for example, this is a representative picture of a child. I don't have the actual picture, but a very similar appearance of a 5-year-old child who was diagnosed as Coats disease elsewhere. It was a blind eye with a neovascular glaucoma diagnosed as a stage 5 Coats. But since the eye was little painful and the family was very keen on retaining the eye, not keen on getting a surgery done, the surgeon gave an option, the retinal surgeon gave an option of draining the fluid and injecting silicone oil so that the structure of the globe could be preserved. So he underwent that procedure. When he came to us, he did have an old B scan with us, and this is what the B scan showed. There was what was presumed as a retinal detachment with subretinal exudates, but if we see carefully, there are some high spikes within the retina, which possibly were areas of calcification. So unless and until we do a corresponding A scan with a B scan, we will miss out these areas of high reflectivity, which could be areas of calcification. And if it's a diffuse involvement of the retina, especially the variant where there is no definite mass in the retina, but the retina is diffusely thickened, which are the cases which present with a total retinal detachment sometimes, we might miss the calcification spots if your cursor is not exactly on the side where the high spot should be. So this child underwent a drainage of the fluid, injection of silicone well with some vitrectomy possibly, and when we saw him 6 to 8 months down the line, this was the picture. Now, there is no doubt about the diagnosis. This is an extraocular retinoblastoma. Typically, if you see, the tumor is coming out from the site where the ports for the vitrectomy were probably made, the supranasal, temporal, and other sites. We got an MRI. The eye was already enlarged in size. There was some thickening of the proximal optic nerve also. So this has already gone beyond the eye. It's an extraocular RB, stage 3. His CSF was negative. He is still under treatment. But this is one situation, probably a little careful assessment could have avoided the child going into this situation. Had an enucleation been done at a stage when the child was here, it would have made a difference of life and death for him. So it's important that, all retinal detachment codes, before we say it's codes and before we do an intervention, we have to be very, very careful. And even if we are planning an intervention, we have to ensure that the drainage is closed as much as possible. And the fluid definitely should go for cytology, even if it is there, so that we are able to pick it up at a stage and do an intervention. Another child, so this child we saw long back, it was referred to one of our outreach clinics. In fact, the child was picked up there. He came to one of the vision centers because the parent gave a history that there was some trauma several months back, and following that there was some redness of the eye, and eventually the eye started shrinking, and they were very keen on cosmetic appearance, so they sent the child for a prosthetic eye fitting to the ocularist clinic. Now again, when we took the history, little detailed history, it was not fitting in. The trauma was too trivial to cause a hyphema and let the eye go into phthisis. So it was not really fitting. Plus the duration between the onset of trauma and the onset of the symptoms there was a several months gap. Generally, parents tend to attribute everything to trauma. It's very easy for them, but we should not buy that history very easily. A little deeper digging is required before the actual picture comes up. So then, since we are not very convinced, we put the child under EUA just to have a better look and also to see the other eye. And this is what we found. There was an anterior dislocated lens. It was a cataractous lens, anteriorly dislocated. There was some corneal blood staining, possibly. But again, the trauma was not getting explaining this dislocation of the lens. So we got an B scan done, as is the protocol for any child presenting with an unexplained phthisis. B scan is a standard, and you can see the evident calcification with an intraocular mass. So this was a little atypical presentation because RB, we know, does not present usually with cataract with lens dislocation, but this child did have that component. Maybe the eye was ophthalmic, the zonules were disrupted, and the lens got dislocated. But what was missing with the initial B scan with the consult initially, which was done with the local practitioner? So, but luckily, since the tumor was already inside the eye, we just enucleated, fitted with the prosthesis, and he was doing fine. So phthisis bulbi can be one of the pretty common presentations of RB, especially in our settings, because more often than not, we see tumors which are pretty advanced. So if the tumor is group E and beyond, and it has outgrown the blood supply, there undergoes tumor necrosis. When the blood supply is not able to keep pace with the growth of the tumor. So when there is a tumor necrosis, the eye gets inflamed. They have picture of anterior uveitis, sometimes the orbital cellulitis, and subsequently the eye will go into phthisis. Now this young child again was sent because the eye was phthysical. There was some episode of cellulitis. Eye went into phthisis. Again, the concern was more from the cosmetic point of view. But as a protocol, again, B scan. This is again a representative B scan. I don't have the B scan of this particular child, but I do have the MRI of this child. Now, when we did UA for this child, we found a small tumor in the other eye. So we did not have any doubt about the diagnosis. But what is striking here, look at the brain. There is a trilateral retinoblastoma, pinealoblastoma. So bilateral RB, we know when they're germline, there is a possibility they can have a pineal gland involvement, and it can be a pinealoblastoma. This child was started on treatment, chemo reduction. He initially responded to some extent to chemo. Even the pineal gland tumor responded, but subsequently it came back. He was a young child. We could not give too much of radiation. He is still on treatment, but we know the prognosis is not that great. So at least even if you're not able to save these children, prognostication is important. Had the pineal gland involvement not been there, it was a bilateral RB, this child could have been easily salvaged. So it's important that we don't disregard all phthisis just as phthisis and have a deeper look, try to kind of understand what is the cause a little better and investigate them specifically. Hypopion and hyphema are other common presentations. So any hypopion where the eye otherwise looks quiet, there is no history, and the color of the hypopion is little different. There is no intraocular, there is no ciliary congestion or any other antecedent history. We might be should be suspicious. At least get a B scan done, even for hyphema. History of trauma should not be taken just like that. It should be taken with a pinch of salt, and a B scan is mandatory even if you are planning any or not planning any intervention for drainage of the hyphema. Anterior uveitis, like this child had a very typical presentation of anterior uveitis where there was a lot of anterior segment seeding of retinoblastoma. In fact, this child was initially treated as anterior uveitis, wasn't steroid. This was again seen by a retinal specialist initially because they found nothing in the fundus. This was the fundus picture, which was a 30-degree fundus picture. Nothing was there. But since the uveitis was not responding, it was sent for further evaluation. B scan, by and large, okay, looks okay on a cursory glance, though if we see carefully, in this area, we can see something near the coats. So there is something there, but if somebody does not see carefully, we'll miss it. On a B scan, we can pick up the calcification, extreme peripheral, but yes, it is there. And when we got in white field fundus photography done, we can see the anterior tumor. So this was a variant of anterior retinoblastoma where sometimes, yep, you want to? Yeah. Yeah, because the color is different. Fungus will be a little more yellowish. The exudates that we see in infection in the anterior chamber, they're a little more yellowish. Retinoblastoma is white and fluffy. They are not yellowish. Yes, and there is lack of inflammation in the eye. Infection in the eye will cause some inflammation, which is missing in this picture. So these, and in a child, unilateral presentation. So these are good enough to raise a suspicion that, it is not really a simple infection, but it's something else. So this child, because there was a lot of anterior chamber seeding, this child eventually underwent enucleation. So this was a variant of RB called anterior RB. Another child, this was a young child with a ophthalmos, but we can see the bad glow in the eye, and there is no doubt that it is an RB with a secondary ophthalmos. In younger children, the eye can enlarge very rapidly, unlike in old patients. So they can accommodate the increased pressure, and you can see some NVI and an enlarged eyeball. So any ophthalmos needs to be, before we do any intervention, a B scan is mandatory to rule out any secondary cause for the ophthalmos. We mentioned about the orbital cellulitis picture, which is essentially because of the tumor necrosis. Some of them can come at a stage, but again, we need to look at the glow. We need to do the B scan. If required, we can get a CT scan done to look for the calcification, and they respond to high-dose chemotherapy. Now, once we have this suspicion, which is going to come from the history, a detailed examination is absolutely important. And history should cover this point: since when, how, what is the birth history, any redness, watering, pain. Most of the things which you discussed needs to be covered. Specifically, vision needs to be checked for. We should look for squint. That can be a presentation of macular retinoblastoma, where the glow, the leukocoria is still not there sometimes, and pupillary reaction needs to be looked at. So this is, and it's imperative that we take up these children under EUA for a more detailed evaluation. Many a times they will not cooperate for the evaluation in the clinic. So EUA almost always has a sequence, how we do it. We check for the anterior, we go from the anterior to posterior, check for the intraocular pressure, check for the anterior chamber, measure the corneal diameter, do an indirect ophthalmoscopy, and if any further investigation like B scan, UVM, whatever is required, fundus photography is required, all these things can be done at the same sitting when the child is still under GA. Once this is done, then we are pretty sure about the diagnosis. And then imaging, if we have not done under EUA, we can get it done. And it's important that a corresponding A scan is done with the B scan to get the correct diagnosis. CT scan, usually for RB, it's recommended. MRI is recommended, but there are certain situations where we get a CT where we have the doubt about the diagnosis, where we are not sure whether it's RB or not. So sometimes to look for the calcification, a CT might be a better option. But if it's a germline tumor, bilateral RB, young children, we generally tend to avoid a CT scan and go for an MRI. Now, in a situation like this, I just put up this slide to emphasize the fact that even in a thysical eye, it's important to do an imaging. Don't presume that thysical eye cannot have RB or cannot have extraocular extension of the tumor. The eye might look thysical, but the tumor might be there in the optic nerve. So that's why it's imperative, like we can see the intraocular calcification in the CT scan in both the eye of this child, which is not in the coats of the eye. Thicical eye can have coats calcification, but any calcification within the vitreous cavity is not normal in a thicical eye. We need to rule out an RB in these cases. Just one more important thing to emphasize before we stop. And imaging is also important in a situation like this. If you see this child, he has an unilateral RB, little elder child, but there is a subtle proptosis of the eye. The eye is slightly prominent as compared to the other eye. Now, if you do not look for it carefully, we will miss this prominence of the eye. And many a times, these are the children who will undergo a primary enucleation. And sometimes an imaging is not done, presuming that the tumor is intraocular, an imaging is not done and this child undergo primary enucleation. Now, a subtle proptosis could be an indicator that the tumor might have gone out to the optic nerve, subtle involvement of the optic nerve, as is evident on the CT scan here. And if we do an enucleation in this situation, and if you don't get an adequate optic nerve, if you cut it here, the nerve seems to be thickened till here, you will end up leaving behind some residual disease, and that is going to drastically change the prognosis. If we know beforehand that there is an extraocular extension, we can give some preoperative neoadjuvant chemotherapy, reduce the bulk of the tumor, and then go for the surgery, which is going to make the surgery safer. So we did the same thing for this child, and after just 2 minutes more. After a couple of cycles of chemo, we now see that the eye has shrunken nicely, the optic nerve thickening has gone down, and at this stage, the surgery is much more safer. And in fact, we recently did a study, it's an ongoing study, pan-India study. We found that almost 15% of the patients of retinoblastoma, many of whom have undergone primary enucleation, a preoperative UA or a imaging was not done before the child had gone for surgery. So that might make a lot of difference, and it's imperative wherever required, we get an imaging. This we already discussed in MRI, bilateral child, germline child, just to rule out an pinealoblastoma. It's mandatory for documentation, a baseline. And going on to the treatment algorithm, it's according to the group of the tumor. Small tumors, just focal therapy like TTT is enough. Larger tumor, we go for chemo reduction along with focal therapy. It could be cryo, it could be laser. And then for vitreous seeds, we have different modalities of management. I will skip this video, how to give the injection. And vitreous seeds respond pretty well to intravitreal chemotherapy these days. And for more extensive retinal tumors like group D and group E, some of the group E, not really all of them, but essentially for group D, we can resort to intraarterial chemotherapy if that facility is available, but we have to carefully select those patients. Generally, right now in our setting, because of the cost and all, we are restricting it only to the secondary patients, mostly to the secondary patients or unilateral group D patients who are not responding to other modalities of treatment or to a conventional chemo. This was one child, unilateral, other eye is enucleated, multiple recurrences, already had, I think, 16 cycles of intravenous chemo, still came back with a recurrence. We gave her a couple of cycles of triple drug ISC and 1.5 year follow-up. She's doing fine. The visual prognosis, of course, is poor. The disc is pale, but at least the eye could be retained. So there are some criteria which are the eye which are suitable for ISC, needs to be carefully decided. The tumors which are coming over the calcification, or there is a recurrence over the calcification, or a localized tumor following chemo reduction, these are good options for plaque brachytherapy, like this child where a plaque was done for the localized residual tumor, responded pretty well. Neoadjuvant, we already discussed. Enucleation remains one of the common modality of treatment, at least in our setting. Important thing here is that if you are doing an enucleation, it's imperative that we take a long optic nerve stump, at least 10 to 15 millimeter, and the histopathologist or a pathologist has to carefully look at the histopathology to look for high risk factor. Whether these children need further treatment or not, we have to figure it out. So I think I'll stop here, and if there are any questions.